Thank you for the introduction, and thank you to the organizers for inviting me to speak with you today about pulmonary MRA. UW does receive research support from GE Healthcare, and the use of Ferumoxytol is off-label for MRA. I'm going to touch briefly on some of the different techniques that we use for pulmonary MRA, and then speak most of the time about clinical applications for pulmonary MR angiography. And in terms of techniques for imaging the pulmonary vessels, we have the same techniques that we've been talking about already today, including contrast or 3D contrast enhanced MRA, whether that's sort of a relatively static but high resolution, high spatial resolution acquisition like I'm showing you here, or time-resolved contrast-enhanced MRA, which, depending on what we're trying to image, we can adjust the parameters to make it a high temporal, low spatial resolution acquisition, or we could make it a low temporal but high spatial resolution acquisition. This I find particularly helpful in imaging patients with congenital heart disease, where having that dynamic information can be very helpful. Of course, non-contrast enhanced techniques or 3D pseudo-steady-state acquisitions are also very important and play an integral part in our evaluation of patients with congenital heart disease. And then finally, 4D flow also has an important role to play in congenital heart disease. We'll hear more about this I think later this week, but also in patients with pulmonary hypertension. So in terms of applications, again, I sort of mentioned in terms of pulmonary vascular disease, I think the three most common pulmonary vascular diseases that we're imaging with MRA are congenital heart disease, pulmonary hypertension, and pulmonary embolism. And of these three, the one that I'm going to spend the rest of the time talking about is imaging pulmonary embolism. For a couple of reasons. It's the application that we image most frequently at UW. Pulmonary embolism is a much more common disease than either congenital heart disease or pulmonary hypertension. And so I think it represents a great opportunity for expanding the use of MRA clinically. And then there's a lot of very interesting challenges that need to be thought about when trying to tailor your acquisition, your scans to image pulmonary MR or image for pulmonary embolism accurately. So how do we do pulmonary MRA for PE? Again, it can be very challenging. We need to cover the entire chest. You need to see all the vessels, from the large central vessels, which measure 3 to 4 centimeters, all the way out to the subsegmental pulmonary arteries that measure just a few millimeters in diameter. So we need whole chest coverage. It needs to be very fast. Patients who are suspected of having pulmonary embolism are short of breath. They cannot hold their breath for 30 or 40 seconds. And so we need to accelerate our acquisition at least less than 20 seconds. The shorter, the better. And then it needs to be very high resolution, similar to CTA, so on the order of 1 to 1.5 millimeters isotropic. Now, this is feasible and has been feasible for several years now using some of the more modern image acceleration methods. This is a diagram showing the protocol that we use in Wisconsin. As you can see, it's very, very simple. I think this is feasible with less than 12 clicks of your mouse, which it probably should be a goal for all MRI protocols. We start with our localizers. Then we have 4 3D MRA acquisitions, 1 before contrast, 3 after contrast. One of those, the first contrast-enhanced MRA, we acquired during the first pass of contrast through the pulmonary arteries, and then a couple pseudo-steady-state acquisitions. And then finally, we wrap things up with a fat-suppressed T1 acquisition. And this can easily be done in less than 10 minutes. Usually it's done in less than 5 minutes. And this is really, really key not only in terms of patient satisfaction, but getting acceptance for this protocol from non-imaging specialists. You know, the ED physicians know that if they send us a patient, that the patient is not going to be gone for 2 hours. They know that they're going to send the patient to MRI, and in 30 minutes the patient is back in the ED room, under observation. Another potential advantage of using MRA for imaging patients with suspected PE is that it's very easy to do MR venography to look for lower extremity deep venous thrombosis without the additional costs of radiation that we would associate with CT venography. Imaging the veins with MR is much, much better than CT. That being said, we no longer do lower extremity MR venography. Usually these patients have already had a lower extremity ultrasound to look for DVT before they've come for their MRA, so we haven't found it to be necessary to improve our outcomes. So when do we use MRA for PE? The most common indication, really the first indication, and the way we kind of got it started, is we looked at it as a way of avoiding any unnecessary radiation in young patients, and specifically young female patients. And so similar to the increasing interest and use of MRI to detect appendicitis, we approached the ED and said, hey, why don't we use a similar philosophy to approach our young patients who we think might have PE. So here's an example from a couple weeks ago. Very quickly scanned the patient and were able to identify a right lower lobe filling defect corresponding to a right lower lobe pulmonary embolism. Now, CT is not perfect either, even though it might be considered the clinical gold reference standard. Many of these studies are also non-diagnostic. Anywhere between 5 and 10% of studies of CTAs are non-diagnostic. Here's one example. Very obese patient that could not hold their breath. We did an MRA, and we were able to confidently rule out any PE. Now, the other imaging modality that is frequently used clinically is ventilation perfusion scanning, and this is available pretty much all over the world, but again, the technetium that is being used can be scarce. It's very expensive. We don't necessarily have nuclear medicine technologists available in-house 24/7, so it might take a couple hours to get that technologist to come in and get everything set up if you've got a patient you want to evaluate at 2 in the morning. Whereas many institutions do have CT techs, or now more and more MR techs that do work 24/7. So MR represents a very nice alternative in these patients to get an answer very, very quickly, and when CT is not an option. Another scenario where we've found MRA to be very helpful is in patients where we know it's going to be extremely difficult to get a diagnostic CT just based on their anatomy. So one example is patients who have Fontan circulation, where there might be some asymmetry in flow from the superior vena cava, kind of diverted to one lung more than the other lung. This is on the left, you're seeing a ventilation or a perfusion scan where they injected labeled RBCs through a right upper extremity vein. Most of the tracer went to the right lung, very little went to the left lung. CT scan showing the same effect, but with the CT contrast. And so in those patients, MRA is wonderful because when you start imaging in the pseudo-steady state or the steady state, all of the vessels are enhanced because the contrast has circulated throughout the body. MRA is also a great option in patients who have allergies to iodinated contrast, in which we want to image them very, very quickly. We don't want to waste our time pre-medicating them before we do a CTA. And then finally, in patients who have renal dysfunction, we can do MRA safely with either gadolinium-based contrast agents or Ferumoxytol as well. So what do pulmonary emboli look like on MRA? They look just like pulmonary emboli on CT. We're looking for filling defects, and that's true whether it's filling defects in the central pulmonary arteries, like you can see in this patient, the lobar pulmonary arteries in this patient with a right lower lobe pulmonary embolism, filling defects in the segmental arteries, and even in the subsegmental arteries. Like you can see in this patient, this was a supposedly healthy volunteer that we scanned when we were testing a new scanner, and we detected an incidental pulmonary embolism. One of the other advantages of using MRA versus CT is that MRA is inherently has higher contrast. We can see the enhancement of the normal perfused lung differentiated from the hypoperfused, non-enhancing lung distal or peripheral to that embolism, similar to what you might see on a nuclear medicine perfusion scan. We do have to recognize the common artifacts with MRA. One of the most common artifacts that we observe is truncation artifact, and if you zoom in on this segmental vessel in the left lower lobe, we see a relatively low signal intensity filling defect in that posterior segmental branch, but that goes away completely on subsequent phases. And Peter Banas, when he was a visiting professor with us a couple years ago, did a nice study comparing the amount of signal drop in those truncation artifacts in comparison to true pulmonary embolism. And the signal drop in truncation artifact is much less than what you see in real pulmonary emboli. Now, we might completely miss the bolus on our first pass acquisition, but that's not a problem with MRA. We just image them subsequent phases later when you're in a steady state after the contrast bolus, and we can get very, very nice images that are, again, diagnostic to the segmental level. A lot of times we've noticed that patients, whether it's with CT or MR, that initial rush of contrast coming through is kind of a shock to their system, and they can't hold their breath very long, or they can't hold their breath at all. Again, because we have multiple phases, you can repeat that acquisition without any problems. And that's true whether they have a PE or they do not have a PE. Now, there have been a couple large studies that have looked at the accuracy of MRA relative to CT. These were done over a decade ago using non-modern accelerated acquisitions. And so over a quarter of those studies were determined to be technically inadequate. Now, in our experience using modern acceleration methods, 15 to 20 second breath holds, we found a technical success rate is on par with CT, over 90%. But more importantly, and if you look at outcomes in these patients, we are not missing any clinically significant PE, and the patients who are imaged with MRA actually suffer fewer complications, probably because we're not anticoagulating patients that don't need to be anticoagulated. We can also detect other diagnoses, like pulmonary dissections, pneumonias, rib fractures, lung cancers, metastatic disease, more metastatic disease. And so you're not going to miss the important stuff that we typically detect with CT. So to wrap things up, there are a variety of MRA techniques that we can use to image the pulmonary vasculature, kind of tailored to the specific clinical scenario. With respect to PE, CTA is still the gold standard for acute PE, but I would strongly encourage you to advocate for using MRA in those that have a contraindication to CT. Rapid imaging protocols are essential. Thank you.